You're listening to Medscape's In Discussion series on esophageal cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Samuel J. Klempner. Dr. Klempner is an associate professor and director of gastroesophageal medical oncology at Massachusetts General Hospital and Harvard Medical School in Boston, Massachusetts. Relevant disclosures can be found with episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, my name is Sam Klempner. I'm a GI medical oncologist at Mass General in Boston. Welcome to this Medscape In Discussion Esophageal Cancer podcast series. Today we'll be discussing GE Junction with one of the global leaders and a good friend, Dr. Yelena Janjigian. Dr. Janjigian is a full professor and chief of gastrointestinal oncology service in the Department of Medicine at Memorial Sloan Kettering. And as many of you know, her research and career in clinical practice are focused on improving outcomes for this patient population. So thank you, Yelena, for joining me.
Thanks for having me.
You're probably starting to prep for your clinic later this week and looking over your new patients. I'm sure there's many of them. When you're looking at a new patient, let's say this is a localized patient, what are you sort of looking for to make sure that been tested so you have a full set of information when you're walking into clinic, biomarkers in particular?
Absolutely. In patients with early non-metastatic disease, it's important to assess tumor location, imaging, and endoscopic assessment of extent of the tumor into the gastrocardia and up into the GE junction and the esophagus. It is also important to have unstained slides or tissue block. We often request that ahead of the visit to make sure that we have critical biomarkers for immune response and chemotherapy resistance, such as MSI, MMR deficiency, which is probably the most important biomarker in early stage disease. And also we get routine testing for HER2, PD-L1, claudin testing, and so forth, because often the metastatic disease declares itself and we need to act on it quickly.
Yeah, I totally agree. Speaking along those lines, a lot of times we'll see an outside endoscopy report that says distal esophageal mass, but then maybe you have a PET scan and it looks a little bit more GE junction or even cardia. Do you routinely rescope these patients? Do you think about laparoscopic staging just to get, as you said, the full set?
Yeah. I think the true esophageal adenocarcinomas, mostly in the United States and in the West, extend and cross the GE junction. So it's critical to repeat endoscopies, and we try to do it at MSK essentially the day after they see me and do a retroflexion to exactly see what you're describing. To extend to the gastrocardia is important for surgical consideration, for perioperative therapy consideration, understanding whether or not a surgeon will be able to achieve R0 resection, perhaps with just chemotherapy or if chemoradiation is needed. And you're right on point about the laparoscopy. In the United States, not enough patients are staged aggressively with laparoscopies, and often metastatic peritoneal disease is missed. And in patients with large, bulky tumors extending into gastrocardia, laparoscopies are important and are done routinely at our sites.
Yeah, there's nothing harder than walking into a surgeon and then surgeon opens up and finds small peritoneal disease that you never know if it was response or resistance or stability and possible without a baseline. You've led several and been involved in multiple non-metastatic trials. Most recently, I think we're all eagerly awaiting the Matterhorn. But as we've seen with the 585, maybe just give us a broad rationale for moving immunotherapy into the non-metastatic setting in GE junction.
Sure. Well, so we know immune checkpoint blockade helps chemotherapy, and in combination with chemotherapy improves survival in stage 4 disease. We know that in our clinics, most of these patients present in early stage disease, even with T3 and 1 tumors. And then after standard chemoradiation, we know that adjuvant nivolumab, if there's persistent and residual disease after complete resection, adjuvant PD-1 blockade can improve survival in those patients. Biologically, we also know from melanoma, lung cancer, bladder cancer, that neoadjuvant treatment, while the tumor is still in place, striking the iron while it's hot, neoadjuvant therapy immunotherapy helps expand anti-tumor immune response early on and then survey micrometastasis. So with that rationale and encouraged by positive adjuvant study, Keynote 585 took chemotherapy and immunotherapy in neoadjuvant approach. So, of course, it was somewhat of a culture shift because it was mostly a study that accrued patients in Asia, where most patients get treated with surgery first and then get adjuvant chemotherapy. And this study also came before FLOT became a globally accepted regimen. So in retrospect, Keynote 585 should have probably focused on triplet chemotherapy regimen, but really it started with doublet chemotherapy regimen in combination with pembrolizumab versus placebo. It was tricky study to enroll to because in the United States, obviously, most patients would get FLOT. And if they didn't get FLOT, then we wouldn't necessarily want to give them cisplatin-based regimens because we're really moved away to oxaliplatin-based regimens. So it was a little bit of a tricky study. We didn't participate in it. It was a big ask in terms of different interim analyses and alphas. In the end, although the Kaplan-Meier survival curves for disease-free survival with placebo versus pembro in combination with chemotherapy did separate, the difference was not statistically significant, and it was a big letdown. The other lesson learned from that study is that you cannot assume that just because you have a pathologic complete response rate improvement, which the interim analysis was positive, you will see a survival difference. We are really getting more picky about these interim analyses because you do lose a lot of alpha with it, and we like to look only if it matters. I think in the future, you and I chatted a lot about this. Perhaps looking at node negative status would be a more appropriate surrogate for these early looks.
Yeah, I think that data on nodal regression is impressive from the UK group and from some of the trials. Let's take it back to the clinic a little bit. So you're a 74-year-old person, you got through 4 cycles of preoperative FLOT, they had a scan, they had some clinical response, maybe it's by PET, maybe it's by CT, and they go to surgery. I'm going to ask you 2 questions. One is, what do you do with these patients who are essentially non-responders? They've limited pathologic response. Maybe they still are node positive. Are you retesting the primary and considering outside the guidelines therapy? Are you rigid with the adjuvant FLOT? And then do you ever think about more than 4 in the preoperative setting based on the scan after, say, 3 or 4 cycles?
Yeah, so I think the total neoadjuvant FLOT is a bit tricky. It's difficult and there's a narrow window of tolerability. So typically I don't do it outside of a clinical trial. We've done it during COVID times if the surgery couldn't schedule it in real time. But typically I don't routinely do FLOT in total neoadjuvant approach. In terms of what do I do with a patient who had almost no response in adjuvant setting to FLOT, we know that switching completely away from chemotherapy is a bad idea. Obviously, Nivo-ITB flopped severely compared to FLOT. It was detrimental. These tumors may still be chemotherapy sensitive. So outside of the guidelines, I do rely on PD-L1 status in those cases. And if the patient had a total gastrectomy or even gastroesophageal surgery, R0 resection, it's very difficult to tolerate FLOT adjuvantly. So I look for any excuse to drop the docetaxel, continue with a FOLFOX, a doublet, especially in a patient in their 70s, and then often add anti-PD-1 if they're PD-L1 high. Essentially, we know that a node-positive tumor with 5 or 6 positive lymph nodes, residual post-FLOT, these patients are essentially stage 4. So the way that I justify it to myself and to the patient, if there's high PD-L1 expression, it's waiting for the tumor to recur and give FOLFOX-Nivo at that time for recurrent disease, or treat the micrometastasis now. And most of the patients really try to get them on chemoimmunotherapy before it recurs.
Yeah, the very fair and reasonably thought out strategy. And I've done the same in a few times. We definitely see changes in PD-L1 expression, whether it's heterogeneity or treatment-induced upregulation remains to be determined. But we do see that, and certainly encourage listeners to retest the surgical specimens at the time of surgery. Let me push you a little bit on future thinking. Let's say you had a regimen with a high biologic activity, something like Keynote 811 regimen in a HER2 positive non-metastatic patient. In these settings, do you think we'll ultimately be able to get to, say, doublet chemo with biologic plus IO, let's say taking the entire 811 regimen into the non-metastatic space? Or do you think we'll need to be block backbone entirely?
I believe that for high overall response rate regimens, we may be able to get away from FLOT. And ultimately, it depends on what our goal is, because it's a seesaw between patient tolerance and being able to get treatment in versus perhaps even non-operative approaches, right? So I think for non-MSI tumors, and HER2 space particular, a game changer would be to skip surgery altogether. It will be a grid of biomarker selection of which subset of patients we can avoid surgery and even get away with a doublet plus chemoimmunotherapy. So let's say it's a MYC wild type, EGFR wild type, high level of HER2 and PD-L1 co-expression. I bet type of p53 mutations in the future will matter, all of that. And then we can stratify patients whether or not they need a doublet or a triplet with biologic and anti-PD-1, and then close surveillance.
Yeah, speaking of that, how we're going to stratify within these groups. Let's say I come to you with a newly diagnosed clinical node-positive GE junction adenocarcinoma, and I tell you right from the beginning, I want to do everything to avoid surgery. Are you checking, or do you do it ever, ctDNA at baseline in non-metastatic settings? And do you think we'll get to a place where the performance characteristics of these assays will ultimately allow us to think about non-operative managements, even in GE junction adenocarcinomas, non-MMR deficient and HER2 wild type?
The short answer right now, none of these assays are good enough for non-MSI gastroesophageal cancer, where I would feel extremely confident watching a patient, especially a young patient. We're just not that good about picking up clinical minimal residual disease on endoscopies. We don't really have a really reliable way to assess them. And ctDNA, Signatera even, and all these assays are just not that good for low TMB, these aneuploid tumors.
Yeah, it's interesting. Squamous shed at like a 7x rate of adenocarcinomas on average. And so we've thought about doing this for some squamous esophageal patients, but I agree it's hard to think about cure without surgery in the current paradigm right now, save for the MMR deficient group that you mentioned. So maybe let's get into that. Remind us a little bit about why MMR testing in the non-metastatic setting is relevant, prognosis, response to benefit from standard chemotherapy, etc.
Sure. So depending on which status set you look at, 5 to 10% or maybe a little higher of gastroesophageal cancers, adenocarcinomas, are MMR deficient. Some of these patients may have de novo Lynch, so it's important to do germline testing. But the quickest way to do is to do MMR deficiency testing on, unstained slides for proteins by IHC. It's quick. And then if they're positive, I think as a surgeon, it's a very satisfying thought to be able to just do an operation and cure someone. 85 to 90% of those patients will be cured with surgery alone. We know that the response to anti-PD-1 therapy by itself or dual combined immune checkpoint blockade ranges anywhere from 60 upwards, maybe 80%. It's not 100% complete response, right? Not the same way that we see in the rectal data, for example, with dostarlimab, but it's pretty close. It's pretty good. So the number one lesson is to test everyone. And number two, realizing that they could probably, if it's a distal gastrectomy and the patient is elderly and you don't want to risk adverse events, get away with just doing surgery, and this patient will not need anything ever. We know that our data shows that if the patient after resection or MSI tumor is Signatera negative, they're not going to recur. If they're ctDNA positive, you have to act on it. So that's where ctDNA would be very helpful to monitor those patients. The big leap forward is to whether or not we need surgery in those patients. And then it just depends, on the patient preference, the likelihood that they're going to achieve complete response, and how comfortable you are with monitoring them closely. At our center, we do offer non-operative approaches with these patients, but we review them carefully at each GMT, and it's tricky. Endoscopies and PET scans are just not that good at predicting clinical and pathologic complete response. You may miss it. I guess that's okay if the patient is willing to get endoscopies every 2 to 3 months, but then it's not a fun thing to do, obviously.
We do the same, and we also pursue non-operative management after informed discussions. But let's say you're going to go down a non-operative pathway and the patient has received essentially a course of immune checkpoint inhibitor. How long do you give the checkpoint inhibitor?
So on the study, we'd give it for 6 months, but because it's part of NCCN guidelines, you could do it whatever basically you wanted to it. So the right answer is we don't know. Probably 6 months to a year. Again, it depends on adverse events, depends on depth and likelihood of complete response. Now we know that not all MSI tumors are the same. We know there's some subsets of mutations that are associated with resistance to immune checkpoint blockade. certainly TMB, heterogeneity of the disease. We've seen patients with complete regression of MMR deficient clone without growth of MSS, non-MSI clone. So this disease is tricky. I think most patients need chemotherapy plus immunotherapy. So the question is, should we give them an MSI setting? We don't know that yet.
I agree. We tend to do 3 to 6 months image and rarely consider longer in people that have had a complete clinical response, although have rarely extended beyond that. All right, let's take our patient who got a perioperative flot, and unfortunately, they recur 6 months later with, let's make it interesting, let's say an isolated lung metastasis. So someone like that comes into your clinic. They said, I have a little bit of neuropathy left over from the adjuvant component of flot, got through it. I'm here in your clinic with really asymptomatic metastatic recurrence. What is your sort of go-to non-protocol management right there?
I don't approach this as oligometastatic, right? That's the path you're going down. I just get them back on chemo, whether or not it's a clinical trial. We do claudin testing and other things. The fact that the patient recurred so quickly and has some neuropathy, we could consider FOLFIRI, ramucirumab as standard practice. But I wouldn't jump into local therapy just yet. Let the disease declare itself, because often on the follow-up scan, there's going to be other things in the liver.
Yeah, agree. Metastatic diseases, practically speaking, for the listeners, this is a palliative setting now, and management of toxicity and quality of life is arguably increasingly important. Are you giving all these patients, let's say it's the same 74-year-old, are you giving them full FOLFOX right off the bat, 5-FU bolus, 85 of oxali, 1200 of 5-FU, or are you saying we've seen some data with non-inferiority with lesser dosing, and how do you think about frontline and someone who's got pretty healthy, but maybe a little bit of leftover tox?
Yeah, I think most people agree that from these Checkmate 649 and other studies, majority of the grade 3-4 toxicity comes from chemotherapy. So if you get them through chemo side effects, immunotherapy, anti-PD-1 doesn't add that much. Other than immune-related adverse events. So how I do it is I drop the bolus, leucovorin, and the 5-FU. I decrease the oxali to 70, 75, and the 5-FU infusion to 1,000. Most patients do quite well. And in the result, you are able to actually get more treatment. And so the dose density overall is better.
Yeah, we follow, I think, a very similar strategy. That GO2 trial from the UK was quite important data to provide some reassurance about even initial dose reductions right off the bat. Across the world, there's variability in screening DPD or UGT1A1 if you're thinking irinotecan. Are you guys considering this? I know our institution doesn't do it preemptively for all patients, but we have considered it in some of our, pharmacy discussions.
I know, and it comes up a little bit now because there's been a lot of more pressure and press about it. The truth is, in the United States, these alterations are so rare, and there's so many different genes can encode the protein, and then there's some still issues. Even if you don't have the mutation, there's a post-transcriptional modification, so the protein may be ineffective. So we give 5-FU so often. And in many cases for curative intent therapy, they would be really detrimental to guests and preclude some patients from receiving 5-FU. So as an institution right now, our position was not to test, but I know there's been a lot of pressure from external bodies, and regulatory authorities are currently reviewing this again. But right now, NCCN and ASCO is not recommending testing.
I know we're getting to the end now, but let's take the same patient. You got him through partial response on FOLFOX and Nivo. Month number 8, they're starting to have a real progression. When you start to think about second-line therapies, and let's say someone without a clear biomarker that you have linked to a trial, I think we're starting to think a little bit more nuanced about just blanketly giving everyone everything or everyone the same thing. When you think about progression on immunotherapy, do you look at the pattern? Do you look at the location? There's a lot of inertia from patients sometimes to think about ablative therapies in an oligo-progressive setting. Maybe talk us through sort of your practical thinking when someone comes in with a scan that shows growth in that liver met that had previously responded.
Close follow-up and symptom monitoring, but also imaging is very important, because I think one of the reasons why you and I probably get more patients onto second and third line therapy, as opposed to if you look at just general population or large phase 3 studies where only 40 or 50% of patients go on second or third line therapy, is because we really watch them carefully, right? And that will improve their chances of responding or at least doing better on and getting to subsequent therapies. There's not a right or wrong approach to this. I typically don't ablate or radiate things that are not symptomatic, especially in a patient with a relatively short duration of response. 8 months is not great, right, to first-line therapy. So that means their systemic disease is the battle. So I try to get them to another systemic regimen. And irinotecan actually has this pretty good track record. The only time I consider ablative therapy or metastatectomy or even removal of the primary tumor is really for these outlier responses where after 2 years on, only the primary tumor is here, or even the primary is gone, and then there's like an adrenal met that pops up. Otherwise, I typically only address symptomatic disease, so radiatable med or things like that.
Thank you. I think that's a very, very helpful framework. This has really been a great conversation. I think in the future, we'll be talking a lot more about newer therapies where I know we spend a lot of our time thinking about how to develop newer drugs and select patients. So today we've talked to Dr. Yelena Janjigian. Thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on esophageal cancer. My name is Sam Klempner, and on behalf of the Medscape in Discussion podcast, thank you very much for joining.
Thanks for listening to Medscape's In Discussion Esophageal Cancer podcast series with our host, Dr. Samuel J. Klempner. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on esophageal cancer.